Welcome, everybody. I'm David Rakoff. I'm the faculty director of the Stanford Center for Population Health Sciences. And the purpose of this session today is to talk to you a little bit more about what we're looking for and what we're interested in, and answer your questions about spectrum pilot grants in population health sciences. So as you're well aware, there's a lot of different types of pilot grants around Stanford that are available, and we want to talk to you about kind of what's unique about this one and what we're really looking for. So we'll start out just with a brief introduction to PHS and then an overview of what we're looking for this year, which is actually a little bit different than what we've done in past years. We're always trying to kind of update and do some new things to do what we think is most useful, especially for supporting T3 to T4 research, to looking at how we can improve health in the population and the community. And then we'll have a little break for questions after I talk about kind of the three tracks for applications that we're looking for. And then I'll turn it over to other folks on the team, Alistair and Bella, to talk about requirements and eligibility, the data that we have available, as well as the application timeline. So I'll be, feel free to put questions in the chat at any time, and folks from the PHS team can answer those real time. But also just note we'll have kind of two breaks for questions. One kind of after about 15-20 minutes here about the different tracks and anything about kind of the main substance of what we're looking for in the applications. And then with more technical questions about eligibility and timeline, or returning to any of those earlier questions, earlier topics at the end. Okay. So the mission of PHS is to improve the health of populations by bringing together diverse disciplines and data, specifically focused on addressing social determinants of health. So this can be, I'm a social epidemiologist, but this can also be in clinical care as well. So looking at how social determinants of health affect clinical care, or preventative care, or public health endeavors in the world of population health. So broadly speaking, a lot of different ways that health can be affected, and we're really interested in the drivers of health at the population level. And so in our focus, our kind of unique contribution is really bringing data to these questions, and in conjunction with data, supporting research using large real-world data sets primarily, and then education around folks learning how to use that data and then translating to the community. So I'd like to talk just really briefly, and I've done this last year at our info session for the grants, but talk about what we mean by population health. I think the great thing about population health is it's a broad term and really inclusive. But on the flip side, it can mean a lot of different things to a lot of different people, and it's so general it can almost be kind of confusing. So I just want to talk about the way we think of that, which I think is helpful for the way our reviewers are reviewing the grants in terms of population health. So if you're interested to learn more, I think this is one of my favorite references on the topic. It's almost 20 years old now, but I think a lot of what they write about here from Kindig and Stoddard and American Journal of Public Health really frames it quite well. So it's really, they talk about an increased focus on health outcomes and on determining the degree of change that can actually be attributed to our work. And so another way to say this is it's really impact focused. So not just on the etiology of disease, not just, the increased relative risk, but actually what the impact is. So from like an epidemiologic perspective, we often think about our public health perspective, population attributable fraction. So like a population attributable fraction is a really kind of population health type metric. It's also a conceptual framework for thinking about why populations rather than individuals are healthier than others, and thinking about the whole spectrum of activities that lead to, in a society, that lead to some populations being healthier than others, and then what the resources are that are needed to change that and make things more equitable and improve health in populations overall. So just very briefly on social determinants of health, we think about this very broadly. It includes healthcare access and quality, education, economic stability, social and community context, and the neighborhood and built environment. So we're really looking to support projects across all of these areas. So not just in healthcare and access, but certainly want to include that as well. But in all of these ways that the worlds where people live can affect their health and can affect the health of populations. So these are some useful references from the Centers for Disease Control and for Healthy People 2030. There are specific goals related to the social determinants of health and addressing social determinants of health to include to improve population health. And that's a big part of when we think about discoveries that are made in the lab through clinical trials in the hospital setting. And then we really think about how they go out beyond that, whether, who benefits from these and whether they're translated into improvements in health in the population. So this is new for 2020. So track 1, we have 3 different tracks of applications this year that you can specify. And track 1 is what we've done, what we have done in the past, which we're just calling here general population health research. So if you've applied before, this is track 1. You can apply to that again. I'll talk about that in a little bit, but then I'll go into details on one other slide on each of these 3 tracks. The second is really Medi-Cal focused research. It's something that some investigators, at Stanford have used Medi-Cal data before, but as Medicaid in California has expanded, as there's more people covered by Medi-Cal data, and then importantly, as we really look at health equity in the way in our research, so who's being reached, we really want to make sure we're reaching the populations that need translation of research the most, which includes Medi-Cal population. So we have a special partnership now. We're obtaining Medi-Cal data right now. We're working on that as I speak. But also there's something more immediate relationship with Mathematica, where we can get folks for these pilot projects access to Medi-Cal data with particular linkages for a project. So if you have a project that you think could benefit specifically from claims data from the Medi-Cal population in California, you could apply specifically to that track. And then thirdly, we really are focusing this year in a new way, and then consistent with Spectrum and the CTSA of looking at translation of work into the community. We're focusing on a community-driven research question examining structural racism in Solano County. And as always, in the past, we're really looking for multidisciplinary teams. That we have a broad definition for that. If there's collaborators at the med school, that come from really different perspectives on their research, we're interested in that. So, we're less interested in you have to check a box. We're really interested in seeing, folks bringing different perspectives to these questions. I think any of the questions in population health really require, they're complex team science type questions. They really require a group of different perspectives to, I think, do the work well. So that's one of the criteria that the referees will be looking at when reviewing the applications. And if you're having trouble, I'll also say here, if you're having trouble finding a collaborator in the past, we've helped to kind of one of our sort of pillars on research and collaborations is bringing people together on projects. So please reach out to us at PHS specifically, if you're looking for a collaborator with a particular area of expertise for a project you'd like to apply for. So first, general population health research, and this was, again, what we focused on last year. It will still be probably the majority of what we'll fund this year. So don't feel that because we have these 3 tracks, we won't be funding very many projects in this area. We'll still fund the majority of projects in this area. We're interested in a focus on social, economic, community, environmental factors and their influence on health, as I talked about in that sort of CDC social determinants of health framework. Also, a project that could be seen to have implications for reducing health inequalities. and then also some thoughts about how this work could be translated into impact. And so, it doesn't necessarily have to be like an intervention. We're not necessarily looking for that, but just as part of your narrative and explaining that there could be a kind of clear, that there's a clear sort of steps forward to what the impact would be of this work on population health. Because I talked about, we're going to have a second track. Probably one of your questions may be how many projects are we going to fund in this area? I'll say we'll fund at least one. If we have some high quality applications in this area that rank above some in the general track, then we would fund probably two of them is what we're looking to do. And so we're really interested in projects that specifically use Medi-Cal data. So we've partnered with Mathematica, who has a lot of experience in working for many decades, and actually, one of the contractors for the Department of Health and Human Services and CMS in organizing and cleaning and documenting missingness and data quality in Medicare data. And so we're partnering with them to make it easier for investigators to get up and running using Medi-Cal data. It's okay if you've already used Medicare data, Medi-Cal or Medicaid data before, you still can apply for this, but also if you've used other claims data before, for example, if you've used our Truven, our market scan data or Optum data, but are interested sort of in expanding to a publicly insured population, we'd really encourage you to think about how you could pivot your project and think about how you could use Medicaid data for that project. So there's some information available, a link here to more information about what's available. But you can really think broadly and creatively about some of the links between the Medi-Cal data and other data sets that are available through the partnership with Mathematica. So here's some more information. I won't read through this, but I believe, the recording will be available, and at the website we'll make this information available so you can have get more of an idea about what could be possible in using the Medi-Cal data. So finally, track 3, which is a little bit of a further difference as well in terms of, instead of a project that's completely driven by the investigators, which, is the bulk of the projects that we fund, we're really interested in trying to help folks at Stanford and kind of matchmake between addressing a community-driven question from a Department of Public Health that we've, through Spectrum, had a long relationship of working with their data, and that's Solano County. And so Solano County, and talking with the county folks from the Department of Public Health there, are really interested in two questions, and you can pick one or the other of these questions to kind of focus on. First is how to operationalize and measure structural racism in a way that would be relevant to local health departments, and particularly county health departments, so that could expand to community-based organizations as well. And the idea here is really something that would be actionable. So I think there's, in my sort of reading of a lot of the work and literature on sort of structural racism in health, there's sort of like two poles where I see a lot of the data, and this is where the question's coming from for them. One is like looking at a lot of sort of outcomes and indicators and documenting that structural racism exists. So this would be, for example, looking at some, the neighborhoods where people live, and then showing, showing disparities in health based on racial distributions of neighborhoods. And how health is affected, for example. But that doesn't really get at, what actions could be taken. So we're looking at things that are a little more actionable. On the other polar opposite, there's a fantastic literature, which is really important, of looking at, historical processes and really like long-term kind of large structural factors that have influenced racial inequalities in health. And that too is, really important work. I don't want to downplay the importance of that, But when we talked with our partners at Solano County, they were kind of interested more in something kind of a bit of a middle ground where they could really say, are we making progress in addressing the drivers of structural racism with relevance for health inequalities? And so, I know this is a very kind of broad framing of these questions, but these were really directly the questions from them, and they're interested in having academic partners to help work on those questions with them. And so I kind of merged these together in the discussion. The second point here in my discussion, is assessing the impact of discriminatory policies. And so, within that domain of measurement, are there particular things to kind of look at that could be metrics and looking at potential impacts that the county health departments could help to address. And I want to make one further note, and I'm happy to talk about this more directly, or folks on the team, Alistair and Eileen and Leslie, are happy to talk with you more. I think especially, happy of course to talk with anyone about their applications for any of these three questions or further questions that we don't talk about here. But in particular, I think if you're interested in this track 3 application, we're happy to kind of give some more background about what the county may be looking for. And for this, it's also a little bit different in that, we're looking for folks who have an interest in working closely with our team and Solano County. So we still want this to be, independent academic research, on these topics, something that would be, working towards potentially a publication, but a little more of a focus on, or much more of a focus here and working with Solano County throughout the duration of the grant to ensure this, the project is really meeting their needs. And so, a bit more back and forth here with the community partner. For this, we're interested in, again, similar to the Medi-Cal track, I think definitely funding one project here if we get, high quality applications of interest, potentially two, depending on what we see. Okay, and with that, we can take a quick break for any questions so far on any of these three tracks, or more questions about population health or what we're looking for with these pilots. And I'm happy to have a nice long pause here for people to think about it. And I'll definitely pause for about a whole minute so you can think if you have any questions. Aaron has a question. Great.
Hey, David, thanks. This was great. I have a quick question about the Medi-Cal data, especially since 85% capitated in the state of California. Are there issues with getting the data from the HMOs that are managing these lives, or are these data coming from Medi-Cal Central, or are they coming from the HMOs, or how has that been working?
So that's a great question. So I don't know the exact answer to that, but that's something that we could definitely reach out to Mathematica about and ask very specifically for your project. So if you could email Eileen and Alistair and myself with that question, then we could relay it to Mathematica and then post it as an answer for everyone to see.
Happy to do that. Thanks.
Great, thanks.
I have a question. I was curious to know, are you funding one project per track, or is more funding towards track 1 and then track 2 and track 3 are going to be one project funding?
Yeah, thanks. A great question. So I think we're looking to fund at the minimum, one project on track 2 and track 3. I think ideally we'd like to fund 2 projects on each of those tracks. And then, it kind of depends on the amount of funding that the highest ranking applications get. So if they happen to be projects that are kind of below the maximum, then we could fund more, of course. But I think, in the past, we've funded Alistair, Eileen, correct me, I think we've funded like 6 total usually. Is it something around 6 or 7?
We funded 7, not 9 the first round, and we funded 7
Yeah.
just recently.
So that gives you an idea. If if we fund sort of 7 or 8 total, that could be sort of 4 on track 1 and 2 Medi-Cal, and then 2 of the public health department, ideally. I'll say, I mean, my take on this would be, and I don't know for sure. Traditionally, we've had that first track. Everyone's applied for that. They're used to it. It'll be interesting to see how many applications we get for track 2 and track 3, because it's something new. And so, I'd encourage you to, if you think, in particular, encourage you, if you have a project for track 2 and 3, to apply, because we may be getting fewer applications for track 2 and 3. Yes, I think I'll let Eileen and Alistair correct me on that wrong, but absolutely you can submit applications to the different tracks. That would be great.
David, can I ask the question?
Yeah.
So for those I noticed last year, it seemed like there were separate funding limits for trainees versus PIs. I noticed that changed this year, but I wanted to ask, from the trainee or pre-doc perspective applying, are there guidelines on what we can request funding for? Because for those of us putting our first applications in, is it fair to, if we don't have data costs, kind of what are the kinds of things that trainees have put in their budget in the past?
Yeah, Eileen and Alistair, do you want to talk about that? I think they'll be getting into that more later. Do you want to answer that briefly now, or do you want to just cover it later in the next section?
Yeah, we'll talk about eligibility in the next section, and we can provide more detail into, if you want to email us, we can give you a list of the things that are typically covered under the grants.
Sounds good, thank you.
Great.
Anyone else with a question that's turning in their head that they might want to ask? Okay, great. Well, I will turn it over. I think Alistair, are you up next?
Yes, great. Hi, everyone. Good afternoon. My name is Alistair Lynn-Dawson. I'm the Associate Director for Research Programs at PHS. So I'm going to go over some of the requirements and eligibility pieces for the grants. So for all the 3 tracks that David mentioned, they're open to both faculty and early career applicants. So early career, we're meaning PhD students, postdoc scholars, lecturers, etc. So all projects must have a Stanford faculty member who's PI eligible be listed as the PI on the application. So early career applicants can be listed as co-PIs. And so if you're a clinical educator faculty member and you're interested in applying, you can request a PI waiver so that you're listed as the PI. Otherwise, you would be listed as a co-PI, and you would still have to find another PI eligible faculty member to be on the grant with you. If you want to go back one more on the slides. Yes, perfect. Thank you. Okay, great. And so another thing to note is the Career Development Award PI waivers don't count for this funding opportunity. This is not a career development award, so that it doesn't apply here. And projects, they must be US based, so no foreign components to them. Clinical trials as defined by the NIH, which we have the link down here, are not eligible for this funding opportunity. And then applicants cannot apply, cannot have one of these grants concurrently with an NIH training grant. So this includes the T series, the K series, etc. And next slide. Okay, and so projects must be completed within the specific grant timeline. There's no extensions, and so we're bound to NIH guidelines around this, and this is an annual program that we do every single year, and so we can't have all of our grants extending into the next funding cycle, it gets very, very complicated. So the funding period is July 9th, 2022, which is when, or July 1st, 2022, which is when the grants will start. And they run for a full year and they end June 30th, 2023. As David mentioned, we're looking for grants that are multidisciplinary. So any projects that span across different Stanford departments and schools are fantastic. The maximum funding amount will be $40,000 per proposal under all 3 tracks. And so this is, as mentioned before, it's regardless if you're faculty or an early career applicant, the maximum is $40,000 total. With that, we still encourage you to apply for less than the maximum funding amount, because that allows us to fund more proposals. So if you have a project that is really interesting and it just takes, 10,000 or something, that is fantastic, because it'll allow us to fund more of those and increase the span of our research. And so I can provide a more comprehensive list by email of what can be covered under these grants, but a lot of times there's salary, data access, publication fees. Those types of costs are often included in these types of applications. But if you want more specifics, I can give you a more comprehensive list if you send us an email. So evaluation criteria. So we will have a faculty review committee that will review all of the applications, and they're going to be looking for several aspects that are listed here. So first off, potential impact. So is the knowledge that's gained from the project likely to inform population health policy, practice, and programs? Does the project have the potential to generate knowledge that will reduce social inequalities in health? The faculty review committee will also look at the methodological rigor of the project and study design. So do the methods have the potential to produce robust and reproducible knowledge? Is a key area of interest. We'll also be looking at the scope and budget. Can this be completed in 1 year? That's particularly important. And then will the project contribute to investigator training is another important piece. And then last but not least, the potential to lead to longer term projects. So these are seed grants. And so we are hoping that they will help launch a project idea and will then branch off into other things, lead to other funding, and so forth. And so if you can make that link in your application of how this will translate into future work, that is fantastic. And then folks who apply under track 3, so reminder, this is the assessing structural racism in Solano County. Those applications will also be evaluated based on how well they would meet the needs and interests of Solano County. So for example, candidates should take into account the knowledge that's derived from the research and how that knowledge could be used by Solano County. And then also taking into account Solano County's resource constraints are really important. So we've included a link down here in the slides of our past projects that have been funded. We encourage everybody to take a look at those before submitting your application. And with that, I believe I'm handing it over to Bella, who will go over the different types of data sets that PHS has available that you might be interested in using for your research projects. Bella?
Great, thanks. So just a couple notes about our data. I'm going to go over kind of the data sets we have, but please note most of these data sets do have some lead time involved for access. So if you think you're going to be using the data for your project, please be sure to go on our portal, and I'll attach links to do that at the end. And you can frequently get metadata access without jumping through all the hoops, just to sort of evaluate the practicality of a data set for your project. So the first data set is called the American Family Cohort. This is a data set that's comprised of about 9 million electronic medical records from almost every county in the United States. And we have up to 10 years of data for some of these individuals. It varies between 2 and 10 years per person. It's particularly rich, and this is a primary care cohort. So if you're doing any kind of project on sort of chronic conditions, things like that, it's a fantastic data set. It does not necessarily include hospitalizations or labs, things like that. Some limitations, it may be sparse in some counties. So again, you may want to look at kind of what you're doing and look at the metadata before proposing this data set. The next is we have some all-payer claims data sets. We currently are in possession of all-payer claims for the state of Colorado. This is about 2/3 of the commercial claims for the state of Colorado. There are some companies that are like self-insured, things like that, that aren't included. So if you want to look at a full state, this is a fantastic data set. And I believe we have 2006 through, I think, 2021. And we have pre-approval. So if you're doing any kind of research on COVID, those kinds of questions are largely pre-approved. And this may not capture uninsured individuals, but is very representative of this state. We have a relationship with the California Agency Data Exchange. These data take a long time to access, so I'd allow a lot of lead time. But they're particularly good for looking at questions for California. So Medicaid is the spine, and then other social services data sets have been attached to that spine. So virtually any question looking at vulnerable Californians, this is a really extraordinary data resource. Next slide, please. Next, we have MarketScan. As many of you are, who have used our data sets before are well aware, we've had a couple large commercial claims data sets, Optum and MarketScan. Optum is being phased out, and so we are in the process of renewing our subscription to MarketScan and bringing that subscription current through 2021. This is a huge data set. It has hundreds of millions of records. I think it's over 100 million records, sorry, not hundreds of millions, over 100 million records, is geographically diverse and has a large variety of payers. And so the other big advantage of this data set is that it has prices. So it's also very good for things like Health Econ, and we have up to 3-digit zip. Some limitations is the de-identification is quite robust. So if you're looking at sort of harder to get things from that perspective, it may not be ideal. And obviously you can't report on providers or payers. You can report on prices, but there's no identifiable information with respect to providers or payers. We do have Medicaid data. We have Medicaid, through Mathematica as described. And so we have either the California Agency Data Exchange or this relationship with Mathematica. So Medi-Cal is data for low-income Californians, a very large fraction of pregnant women and children from lower-income families. And then finally, we have Medicare. We have a 20% sample for the years of 2006 through 2018. This is 20% of all Americans over the age of 65, so it's extremely representative for that population. It's very granular, it's very rich. And again, you know, these people are followed longitudinally for a long time. So this is a fantastic resource if you're looking at older Americans. Next slide, please. So this is just sort of and again, you know, this is everything I just said, but I'm kind of presenting all the information here. So when we send out the slides, you can kind of look and see what it is you need for your project. Next slide. And here I have our descriptions of the data sets, the process for applying, the data portal, the PHS data user Slack channel, and some information about our computational environment. And so for access to the data, to look at the metadata and to kind of poke around and see if these data sets are a good fit for your project, you're going to need these links. And so after this, we'll be sending these out so that you'll be able to review and see if these data sets are a good fit. So that, next slide, please. Next slide, please. These are some additional resources, and then at the end, I can take questions about the data sets.
Thank you, Bella. So now it's my turn. I will, as Bella had mentioned, I'm sorry, this mic here. As Bella had mentioned earlier, in addition to facilitating access to comprehensive, well-curated population level data sets, we can also provide you other resources that will enhance your research. And, you know, a lot of you, this might be very useful to you, especially in your early stages of your academic career. We have, as you can see here, PHS can also offer funding support. This is not just limited to sponsoring research projects through our grant opportunities, such as the pilot program, but we can also offer services in helping you identify potential new funding sources and could provide advice and guidance on your proposals prior to submission. Earlier, David mentioned about assisting you with collaborators. So we also offer extensive network support or matchmaking, and where we can help you here connect your research ideas with other faculty and trainees who may be exploring similar topics or may have an alignment in their research. We have an extensive network of partners and collaborators, both in Stanford and outside the Stanford community, both in the US and even internationally. In addition to that, we recognize that the most impactful population health research must incorporate some level of community engagement. And as a result, we can provide assistance in making those linkages either through our close connections with the Stanford Office of Community Engagement or by connecting you with some of our local partners throughout the Bay Area, including county public health departments. And we had mentioned earlier, Solano, San Joaquin Valley, and things like that. We also offer research management support for projects in which PHS is more directly involved in. We may also provide management support to help move your work plans forward and convene stakeholder meetings to really drive your projects forward. And last but not least, we have dissemination. We want to make sure that the research being conducted at Stanford doesn't just stop at publications, but gets into the hands of the people who need it most, whether that be policymakers, community organizations, etc. So we can also support the dissemination of your work and potentially help you tailor your research outputs in a way that is easily accessible and digestible to the target audiences. And now that I've mentioned the additional PHS research resources that we have, let me just give you a quick overview of the timelines before we move to the Q&A. So as mentioned, you probably already have heard that all our applications are due on March 31st. It is now open, but we will close at March 31, 11:59 p.m. We will have the award notifications go out by email no later than Friday, May 6th. And we have this special pilot award office hour session for just accepted final grantees. Please do mark this on your calendar now in case that you will be one of those selected finalists. It's on Wednesday, May 11, from 11 to 12. And this office hours is really important because there will be some additional materials that you'll be needing throughout the month of May. You need to submit in May in order for the awards to be given to you. So this will be like things like NIH, bio sketches, IRB approval, final budget justification, human animal subject termination, requirements. These are things like that. And this session, you will go through all these materials to make sure you understand what is needed, and will be facilitated by Ellen, who's here with us, and Peg Chow. Both are the experts when it comes to the details that you'll be needing to submit. And depends, of course, if you are able to give this in time in May and finish it in May in order to be receiving your funding. You are more than welcome to act on these pieces now, but we will not ask for them until you have officially been selected as an awardee. So I think with that, we will now go to the last one, which is the funding period. And Alistair had mentioned this earlier, that the grant timeline starts on July 1st, 2022. It will go for a year, June 30, 2023, and there are no extensions. For any questions, you can direct them to me through the stanpophealth@stanford.edu. And I will be administering regarding questions related to project scope, application review process, and award notifications. Ellen Orasa, who is here at eorasa@stanford.edu, please direct your questions to her if they are related to eligibility, application documentation, and online application submission. We will be posting this at the end of the session today, but of course, we will also be sharing the slides. So I guess we can move on into the Q&A. And just so as a reminder, both the slides and the recording from this session will be posted on our website. We encourage you to check out the links and references in the presentation. There were a few from David, some from Bella, and even from Alistair, and a few from me too. So these links will be shared on our website together with recording. We also encourage you to check out the descriptions of the current pilot projects that we have, as well as to give you a chance to see what types of research we had funded before. So now I will just go ahead and open it up to questions. We've allowed folks, as David has done earlier, you can unmute yourselves, you can ask questions, you can use the raise your hand feature if you wish. Okay, let me stop share here. And we have a team here from PHS as well as from the Spectrum to help us answer your questions. If you don't have any specific questions, of course, and don't feel comfortable in this setting, you can absolutely email Ellen and I, and we can also go from there.
And I'll also add anybody who's interested in applying for the Medi-Cal track, we encourage you to definitely reach out to us before submitting your application to get a better sense of some of the details that you would need to include in the application related to accessing the data. So you would need to include a piece, the cost piece in your budget and so forth, which is information that we can provide for you. So please do reach out to us if you're applying for the Medi-Cal track. I see there's a question from Noor. It says, do we have to include preliminary data and IRB approval along with the proposal? Ellen, please correct me if I'm wrong, but I think no, you don't have to provide it with your proposal, but you will need to have that in place prior to the start of your project on July 1st. Is that correct, Ellen?
Yes, that's correct.
Okay. And so on that vein, if you can start that process now, it's going to save you a lot of headache as we get closer.
It's taken people much longer than they expected.
Exactly. Yeah. And that is very challenging, especially since we can't offer extensions. And so if that process takes longer past July 1st, that just eats into your time that you have available to do your project. So you would then only have 9 months, for example, to complete the project, since the end date of the grant is a hard stop. Any other questions?
Let me post the website, by the way, in our link here too.
Thank you. Bella, I had a follow-up question for you as you're going through those data sets. Sure. Of those data sets, which ones would potentially take longer than 3 months to actually be able to access the data?
I would say if you want to use the California Agency Data Exchange, reach out now. We're going to start you through that process because you want to be pretty sure you can get access to the data before including it in the pilot grant. The Medicare and Medicaid data sets take 2 to 3 months. So the lead time you need is in the table that we'll share.
And what about AFC?
AFC is probably a week or 2. You'll need an IRB to actually access the data. So that's sort of the rate limiting step. But in general, our IRB is pretty quick, like maybe 2 to 6 weeks at the most.
Thank you.
Let me just post this last slide in case some of you have not, seen it in chat, and also the website links are here.
And there was one more question from Stephanie. Did the emails listed here include queries about collaborations too? Yes, so for questions about collaborations, data access, you can send them to Eileen, the Stan Pop Health at stanford.edu.
There is another question, I think. Let me see.
It's about the food.
Yeah, so there was another question. Is the data set limited to the ones you showed? Are the data sets limited to the ones we showed? And can we use other data sets? Yes, absolutely. The ones that were displayed by Bella were just ones that we specifically offer through our data portal. You can use other data sets, absolutely.
There's another question on, can food be an allowable expense if it's used as part of the study? And maybe Ellen can help us answer this question.
Food is unfortunately not an allowable expenditure. Allowable expenses include investigator salaries, research personnel salaries, travel if they're project related, and for project supplies.
Is that true? Because my understanding of that rule is really because they didn't want people ordering food as for meetings and things like that. Is it still true when it's actually part of the research itself?
I think that we would have to look at the project. I'm not 100% sure. I totally get what you're saying because I know that there are lots and lots of studies that include food for any number of reasons, as they would include a supply. So I'm not sure that we can be absolute on that. I think we would have to just look at the project and potentially ask NIH.
Makes sense.
And one question that came through is, as I mentioned earlier, that the recording would be posted on our website as well as the slides. Give us until about, as soon as we can, we'll get it, maybe until tomorrow to get this posted.
Great. I think last chance for questions, and then we'll sign off. But thank you so much, everybody. We appreciate your, was there one more question?
Yeah, it says, do you have the schedule for when the next training sessions for Optum data will be offered? Unfortunately, and we had sent out a blast to all of our data users, Optum is discontinuing academic data licenses. So we are in the process of decommissioning access to Optum. So it would not be an appropriate data set for these projects or really any new projects at this time.
There was a question posted.
I don't know if it helps for this round, but we are looking at other claims data sets that we may offer in the future.
Right, and just to be clear, MarketScan is a great substitute for Optum. It doesn't have quite as granular of a geography, but it's very good in terms of its coverage, and actually more socioeconomically diverse because it's more payers. And then the state of Colorado claims data it's not as many people, but it's a whole state, so it's much more representative of a population than just one payer.
Yeah, I would encourage the person who's interested in claims data to reach out to us because we have several different paths that are open.
And although I think Ellen had already answered the question, the allowable expenditures can be used for a postdoc salary as well, and Ellen had confirmed this. I think that's all we have. Please feel free to reach out to us. We're more than happy to, we look forward to your questions. We'd like to answer them. And of course, you can either email it to us, or if you'd like to even schedule time, for regarding your scope, discuss it in a one-on-one call, also let us know. We'll be happy to facilitate that as well. So if there's nothing more, thank you very much, everyone. And we will be posting the slides and recording. Do check out our website.
Thank you, everyone.
Thank you very much.
Thank you.
Bye.